Welcome. Today, we are reviewing the 2025 Clinical Blueprint for Neurofibromatosis. This update is specifically designed for pediatricians, general practitioners, and allied clinical staff to synthesize the 2021 and 2022 International Consensus Guidelines along with groundbreaking FDA approvals from recent years. Let's jump into the core changes affecting your daily pediatric practice. To begin, we must recognize that we are dealing with three distinct genetic and clinical conditions. NF1 remains by far the most common of the three. It is tied to the NF1 gene, which codes for neurofibromin. Its clinical hallmarks include café-au-lait macules, neurofibromas, skin fold freckling, Lisch nodules, optic pathway gliomas, and bone dysplasias. NF2-related schwannomatosis is caused by mutations in the NF2 gene coding for Merlin. Its signature hallmark is bilateral vestibular schwannomas. Crucially, the term NF2 was formally renamed in 2022 to reduce clinical confusion with NF1. Other schwannomatosis is a category involving mutations in genes like SMARCB1, LZTR1, or other 22q-related defects. It typically presents with multiple non-vestibular schwannomas and is characterized by chronic pain. It is genetically and clinically separate from NF2. Let's zoom in on diagnosing NF1. Under the revised 2021 criteria, a formal diagnosis requires meeting at least two of these 7 markers. 1. 6 or more café-au-lait macules measuring greater than 5 mm prepubertal, or greater than 15 mm postpubertal. 2. Skin fold freckling located in the axillary or inguinal regions. 3. 2 or more neurofibromas of any type, or a single plexiform neurofibroma. 4. An optic pathway glioma. 5. 2 or more Lisch nodules or 2 or more choroidal abnormalities. Note that near-infrared imaging or optical coherence tomography is now a formally accepted alternative to detect these. 6. A distinctive osseous lesion, such as sphenoid dysplasia or anterolateral tibial bowing or pseudarthrosis. And 7. A germline NF1 pathogenic variant. This molecular confirmation is now formally established as a standalone diagnostic criterion, moving genetic testing from a purely confirmatory tool to a primary diagnostic pathway. A massive clinical challenge in pediatrics is the presentation of a young child with only café-au-lait macules and skin fold freckling. This child requires genetic differentiation to distinguish NF1 from its lookalike, Leger syndrome. While both share the café-au-lait and freckling phenotype, they are entirely different. NF1 involves the NF1 gene on chromosome 17, carries a high risk of benign and malignant tumors, features learning differences, and requires strict, lifelong clinical surveillance. Leger syndrome, on the other hand, is caused by a mutation in the SPRED1 gene. These patients do not develop neurofibromas, Lisch nodules, optic gliomas, or bone dysplasias. They carry no increased tumor risk, experience a much milder natural history, and though learning differences can occur, they are generally milder. Identifying Legis early prevents unnecessary anxiety and intensive tumor monitoring. For a child with confirmed NF1, your role as a pediatrician is to serve as the clinical coordinator using this system-by-system surveillance map. Ocular, conduct annual ophthalmology exams through age 8 to screen for optic pathway gliomas, and monitor for strabismus or proptosis. Endocrine, plot height and head circumference regularly to monitor for precocious puberty or short stature. Skeletal, assess for tibial bowing during infancy to prevent pseudarthrosis, and screen for scoliosis at every single visit. Neurological and developmental, screen early for learning differences, ADHD, and autism spectrum features, which have an estimated 50% prevalence in this population. Cardiovascular, check blood pressure at every visit to screen for renal artery stenosis and pheochromocytoma. Dermatological, track café-au-lait count and size, while actively checking for new or rapidly changing subcutaneous masses, which could indicate plexiform neurofibromas. To understand how our new targeted therapies work, we have to look at the molecular pathway. Normally, the NF1 gene produces neurofibromin, which acts as a biological brake to turn RAS off. In NF1, a loss-of-function mutation means this brake is missing. RAS remains chronically on, triggering an unregulated downstream cascade through RAF, MEK, and ERK. This unchecked pathway drives uncontrolled cell growth and the development of plexiform neurofibromas. Rather than trying to fix the missing upstream brake, modern therapeutics use a MEK inhibitor. This acts as a molecular wedge that blocks the pathway downstream at MEK, successfully halting tumor growth despite the hyperactive upstream RAS activity. Currently, we have 2 FDA-approved MEK inhibitors targeted at symptomatic, inoperable plexiform neurofibromas. Selumetinib, also known as Koselugo, was approved in 2020 for pediatric patients aged 2 years and older. Its approval was expanded to adults in November 2025 following the COMET trial. It demonstrates an overall response rate of roughly 44% to 66%. Keep in mind its safety profile, which includes acneiform dermatitis, elevated CPK, diarrhea, and paronychia, with warning signs for left ventricular dysfunction and ocular or gastrointestinal toxicity. Mirdametinib, also known as Gomekli, was approved in February 2025 simultaneously for both adults and children aged 2 and older based on the RENOI trial. It boasts an overall response rate of about 41% in adults. A major clinical advantage of mirdametinib is its delivery system. It is available as a capsule and a tablet for suspension. This is crucial for younger pediatric patients who are physically unable to swallow capsules. It shares a similar MEK inhibitor class side effect profile with selumetinib. Now let's pivot to NF2-related schwannomatosis. The 2022 consensus simplified the older Manchester criteria and officially retired the confusing term NF2. An immediate diagnosis is confirmed if the patient presents with bilateral vestibular schwannomas, OR has an identical NF2 variant across 2 or more anatomically distinct tumors, such as a schwannoma, meningioma, or ependymoma. If they do not meet that immediate equation, you will evaluate major and minor criteria. Diagnosis can be reached with 2 major criteria, such as unilateral vestibular schwannoma, a first-degree relative with NF2, 2 or more meningiomas, or an NF2 variant in unaffected tissue. Alternatively, you can diagnose with 1 major plus 2 minor criteria, which include ependymomas, meningiomas, juvenile cataracts, or retinal hematomas. While the primary management of NF2 remains led by surgery and radiosurgery, systemic, targeted therapies are rapidly altering the multi-tumor landscape. Bevacizumab is our established anti-VEGF option. It shows about a 38% radiographic response and a 45% hearing response in progressive vestibular schwannomas. However, it is strictly reserved for progressive cases because of cumulative toxicity concerns, specifically hypertension and proteinuria. Brigatinib is an exciting emerging multi-kinase inhibitor. A phase 2 basket trial demonstrated activity across schwannomas, meningiomas, and ependymomas, representing a massive shift toward pathway-targeted therapy across the entire tumor spectrum. Lapatinib is an EGFR HER2 inhibitor that has shown only modest, limited responses in vestibular schwannomas. To make this actionable in your clinic, here is your referral trigger board. Standard referral. Any patient meeting 2 or more NF1 diagnostic criteria or presenting with strong clinical suspicion should go to clinical genetics and pediatric neuro-oncology for confirmation and baseline surveillance. Priority referral. A child presenting with only Café-au-lait macules and freckling by school age needs a genetics referral to distinguish NF1 from Leger syndrome. Similarly, any plexiform neurofibroma causing pain, disfigurement, or functional impairment warrants a priority referral to evaluate for targeted MEK inhibitor therapy. Finally, bilateral hearing loss or a family history of NF2 should trigger a priority referral for audiology and an MRI. Urgent referral. Any patient with a new or rapidly changing subcutaneous mass, especially if accompanied by pain or rapid growth, requires urgent escalation to evaluate for malignant peripheral nerve sheath tumor transformation. To wrap up, let's consolidate the 4 critical updates changing your daily pediatric practice. 1. NF1 now includes molecular testing. Finding a germline pathogenic variant is now a standalone diagnostic criterion. 2. Do not miss Leger syndrome. Café-au-lait macules and freckling alone warrant genetic testing to rule out this entirely distinct, milder condition. 3. The term NF2 is outdated. Ensure you update your documentation and parent counseling to reflect the correct taxonomy, NF2-related schwannomatosis. 4. MEK inhibitors have changed the landscape. Both selumetinib and mirdametinib are powerful, approved targeted tools for inoperable plexiform neurofibromas, making early pediatric referral crucial. Thank you for your time and your continued dedication to optimizing care for these patients.